Let's talk about dialysis and the functions of it. It rids the body of excess fluid and electrolytes. It achieves acid-base balance, and it eliminates waste products. It also restores internal homeostasis by osmosis, diffusion, and ultrafiltration. Dialysis extends life and sustains life for individuals who have acute and chronic renal failure, but dialysis does not replace the hormonal functions of the kidneys. It's only the excretion, electrolytes, fluid balance of the kidneys, not the hormones. And two types of dialysis that we're going to be talking about are hemodialysis and peritoneal dialysis. We see dialysis used for individuals who have renal insufficiency for both acute and chronic renal failure. Perhaps you would see it used for drug overdose. If someone has persistent hyperkalemia and hypervoluemia, or too much fluid, that is unresponsive to diuretics. These patients present overall as subjectively with fatigue, numbness, and tingling of their extremities. They may have shortness of breath, anorexia, and dry, itchy skin. Objective signs and symptoms that we will see is lethargy, maybe they'll have a decreased attention span, seizures, tremors, hypertension, heart failure. So we would see those signs of heart failure. Maybe we'll see edema, dyspnea, JVD. They may have anemia, vomiting, pulmonary edema, dysrhythmias. There could be pallor, bruising, halitosis, which is bad breath, and diminished or dark-colored urine. Our goal of dialysis is to achieve and maintain the desired fluid and electrolyte balance and be free of infection, as well maintain a lifestyle with minimum restrictions for these individuals who have failing kidneys. Hemodialysis. It actually shunts the patient's blood from the body through the dialyzer and then back into circulation. So they have to have a vascular access for hemodialysis, and that could be some type of surgical shunt, or we can also do it with external vascular access through a subclavian port, or a port that's been placed that has external a catheter of types. So we want to make sure when we have these patients that there's patency of their access site. So if it's a surgical placement, we're going to look for the presence of a bruit, which is where we're going to listen to that turbulence. We're going to look for a palpable thrill, so we're going to fingers over it and feel that turbulence inside the site. And also we're going to look for distant pulses and circulations. With our patients who have had an access established, we want to make sure that they check that every day themselves. It's good to teach them the first thing in the morning is that they just put that access right up against their ear, whichever side of the head it's on, as long as it's on their arm. It's supposed to be difficult to get their leg up there. Anyways, so put it up to their ear and listen. Can they hear the turbulence, and can they feel the thrill against their ear? Or you can teach them how to do it with a stethoscope as well. But just for them to place it up next to their ear, they can check it every morning because they need to know that it's patent. We want to make sure that there's blood pressures are not taken on the arm that has the access site. That they are not getting any injections on that site. Venipunctures are not being done. There's no IVs on that side. That side is sacred. We're trying to preserve that site. Once during the post-operative period after it's established, there's a rest period. We want to make sure that they elevated their extremity when they first come back from surgery to decrease swelling on it, and it takes a length of time before they actually can use that site. We need healing to occur and the fistula to develop. We're going to check prior to dialysis. Before they go off to their hemodialysis, we want to make sure that they we know their vital signs, their labs. We're going to look at viewing creatinine, electrolytes, hematocrit. We want to know what their weight is because we know how fluid can change weight. We're going to discuss with the doctor what medications need to be given or need to be withheld till after dialysis. Usually we will see medications that are dialyzed off, held till afterwards, and any medications that lower the blood pressure are often withheld as well. So you need to make sure what the physician preference is, and these are individual case-by-case basis typically. Your patient needs to be instructed about the procedure. Often you're going to run into these old wily dialysis patients that have been doing it a long time, but they typically are done 3 times a week in 3 to 5 hour sessions, and 2 needles are inserted, one into the artery side and one into the vein side. Now, if you are a dialysis nurse and you're sitting at your dialysis unit and you're having difficulty with your new patient showing up for their treatments, which are 3 times a week, you need to get someone in to talk to them about accepting their disease, because if they don't come in for dialysis, they're just going to get sick and they could end up dying from renal failure. So we want to make sure that the patient will let us know of any muscle cramps, headache, nausea, dizziness during the procedure. So during that procedure, we're going to keep an eye on vital signs. We'll pull lab values off while we're dialyzing the patient. And I'm speaking we as in the dialysis nurse, because typically if you have an acute patient in the hospital, the nurse comes to the patient and it's not the bedside nurse that's doing dialysis. You need to be have specialized training in this. But we're going to monitor for bleeding, any oozing at the insertion site. They're going to look at the coag studies. They may be giving anticoagulants if there's any prescribed. Typically it's heparin. And then also they're going to want to have protamine sulfate on reserve in case we need it, because that does reverse heparin. Provide the patient with emotional supports. Remember, it's 3 to 5 hours. It's boring. Often these units have books, magazines, movies. Often patients, this is their social time. They're friends with their Monday, Wednesday, Friday dialysis friends that all come in at 10 o'clock on those days. They may play cards or games, whatever, to occupy the time. Post-procedure, we're going to look again at vital signs, lab values, viewing creatinine, electrolytes, hematocrit, and a weight. Decreases in blood pressure, decrease in weight, and lab value changes are expected with dialysis. We think that's going to happen. In fact, we hope for that to happen. We're going to look for any kind of complications. Is there hypotension? Did we take up too much and we put them into hypotension? Is there any clotting in that vascular access? Do they have headaches, muscle cramps, bleeding, disequilibrium syndrome? And I'll go into that a little bit later. And then nausea, vomiting, and any signs of hypovolemia. We want to make sure that our patients are not lifting anything heavy with that access site, and not to compress that extremity. Don't carry something that's going to be across your access site, like a woman with a heavy purse. She doesn't want to carry her purse strap across that access site. They may want to, you may be teaching hand exercises that are going to promote that fistula maturation, and you want to check that site following the dialysis, because we don't want them to bleed from there. You could put a light pressure on, but you don't want to occlude it. Okay, now I said I was going to get into the complications. Complications, which is clotting and clotting or an infection of the access site. Because we often give anticoagulants to prevent clots from forming, we could have some bleeding there. Infections at that access site are introduced because of the cannulation, so we want strict aseptic technique. Now, as our patients get older, there's a risk for access site complications related to, chronic illness, fatigue, like real fragile little veins, and they just blow out a lot easier. So we want to make sure that we're using surgical aseptic technique during cannulation. No compression, I said that before. Any anticoagulants as needed. Always palpate for thrill and listen for the bruit. And look for signs and symptoms of infection, which would be redness, swelling, drainage, or monitor the patient for fever. And we're going to teach our patients all of these things as well. That disequilibrium syndrome is caused by too rapid a decrease in BUN and circulating volume, and that can result in cerebral edema and an increased intracranial pressure. So early recognition of this disequilibrium syndrome is very essential, and those signs and symptoms are a change in level of consciousness, nausea, vomiting, seizures, and agitation. With increased age, we're going to see an increased risk factor for that for happening, so our elderly are more likely of getting that. So we want to use slow dialysis exchange rate, so it's not like, don't do it rapidly, don't do that 3-hour session in 2 hours. And this is especially important for the older clients and anyone who's getting hemodialysis for the first time. In the case of seizure activity, we would be giving anticonvulsants. We want to notify the physicians, and then if we have any of those early signs such as nausea and headache, we go ahead and call the doc as soon as possible. Hypotension is another complication of hemodialysis, and that's rapid fluid depletion during dialysis can cause it. It also could be caused if the patient got their antihypertensive, or if they have some vasodilation going on because they ate prior to the dialysis. So that could cause their hypotension. So we're going to carefully replace the fluid volume, a slow exchange rate. We're going to lower their head down if they get hypotensive, monitor for severe hypotension. If they're unresponsive to the fluid replacement, it's not bumping back up, we may have to stop the dialysis. So we want our patients to let us know if they're feeling any headache, nausea, dizziness, and if we don't want them to eat during dialysis because they may get that vasodilation from food ingestion during dialysis may occur, and then they'll drop their pressure. Anemia is another complication, and that is blood loss and removal of folate during dialysis, and it can contribute to an existing anemia, and that often occurs with the chronic renal patients. It is caused by a decrease in RBC production because there is a decreased erythropoietin secretion. So what are we looking for with these patients? We're going to give them erythropoietin to stimulate their red blood cells to produce. We're going to monitor their H&H and their RBC levels. We're going to look for hypotension and tachycardia, and we're going to transfuse any blood products if needed. We're going to advise our patients to make sure that they take all their meds and supplements as prescribed. And like I said earlier about the patient that doesn't show up to dialysis appointments, if we have trouble with them taking their medications, we might want to call in some help for that as well, and that maybe we need a psych case manager or someone to assess what's going on. We want to talk to them about their diet, nutrition, including foods that are high in folate, such as beans and green vegetables. Another complication is infectious diseases, and frequent blood access happens, transfusions happens. They have an increased risk for the transmission of bloodborne diseases. So those would be the hepatitis and HIV. So we want to make sure that there is sterility in the equipment. We're using standard precautions. We're giving meds, especially erythropoietin as prescribed, and make sure those patients take their meds as prescribed and their supplements, and educate them on their diet. Okay, peritoneal dialysis is the installation of fluid into the peritoneal cavity, and the peritoneum serves as a filtration membrane. So the patient has to have an intact peritoneal membrane, and they can't have any adhesions from infection or multiple surgery. So this it will eliminate a certain percentage of the population. So they do have to have that intact peritoneal membrane. It is often used for clients who are unable to tolerate anticoagulation and have difficulty with the vascular access. So what we want is for our patient to have desired fluid balance. We want them free from infection, and we want them to have an active lifestyle as much as possible. Pre-procedure with our patients, typically they do this at home, but say we're taking care of them. We're going to assess their dry weight, and that's once the dialysate has been drained, what their electrolytes, creatinine, BUN, and glucose is. And we want to determine whether or not the individual is able to do this by themselves. So, we eliminate those who have had multiple surgeries and don't have that peritoneal membrane, and then we're going to eliminate those who are unable to manage this process, which is difficult. So only a certain special population can manage self-peritoneal dialysis. You have to teach the patient the procedure, and that they're may feel this fullness when they have the dialysate in their dwelling, and there may be some discomfort initially with the dialysate infusion. Continuous ambulatory peritoneal dialysis, which is CAPD, is done 7 days a week for 4 to 8 hours, and patients actually continue on with their normal activities while the dialysate is in their dwelling. So that's another subtype of this. During the procedure, we're going to monitor their vital signs during the initial dialysis of clients in the hospital. If they come into the hospital and they are on peritoneal dialysis, they are very, very fussy, and they should be, as to how this is done. So if you're uncomfortable at all in doing this, make sure you have someone there who has done it before, and listen to what the patient has to tell you. We're going to be watching their glucose level. We're going to record the amount of inflow compared to the outflow of the dialysate. We're going to have a real close look at the color. We expect for the dialysate to come out to be a clear light yellow, and the amount should be equal to or more than what we put in. So we want to pull from them. We're going to look for signs and symptoms of infection, which would be fever, bloody, cloudy, frothy, dialysate return. If it has kind of a murky look to it, if it has a brownish, the affluent is what it's called, is discolored, we're concerned about peritonitis. We're going to look for any signs of respiratory distress, abdominal pain, if we're not getting enough outflow, and if it is discolored. We're going to look at the site and assess for any wetness, because we don't want any dialysate leakage. And prior to instilling the dialysate, we want to make sure it's the correct temperature. We don't want to put it into the microwave because the microwave will heat it unevenly, so we want to make sure that we put it in the proper heating device if one is available, or we're going to pull it out of a cold room and warm it up somehow, but not in the microwave. We follow the times of the infusion, the dwell, and the outflow. Very strictly, we're going to do that. Maintain surgical asepsis during this procedure of the catheter insertion site and when accessing the catheter. We're going to definitely keep the outflow bag lower than the patient's abdomen. We want to talk about gravity. It drains by gravity. We don't want any reflux. We're going to reposition the patient if inflow or outflow is inadequate. Maybe they just have to change their positions, their body position a little bit. And sometimes the peritoneal dialysis catheter will get a fibrin clot in it, and we have to be really careful about milking that. So if we have to pull or break down that fibrin clot for outflow, carefully milk it. and definitely want to provide support for the family. Post-procedure, we're going to be looking at the patient's weight. We're going to look at their electrolytes, creatinine, and glucose. And definitely we will be teaching the patient how to care for that access site when they're new to it. And if they're new to the hospital and they've had it for a while, they will be teaching us about it. Complications that we would see in peritoneal dialysis include peritonitis. It's the number one and the worst one. Because peritoneal dialysis can have microorganisms and allow microorganisms to come into the peritoneum, it could cause peritonitis. So that's why we are strict surgical asepsis with this procedure. We want to monitor our patients for signs and symptoms of infection, which would be fever, purulent drainage, redness, swelling, cloudy, or discolored dialysate on its outflow. Make sure we teach our patients to do that during the exchanges, to be strict sterile technique, and to notify the provider immediately with any hint of infection. So if we see infection at the access site, it could be related to the leakage of the dialysate. They can cause peritonitis as well, infections at that site. And anyone who has an advanced age, which is our elderly population, they have even further complications related to chronic illness, so they're at higher risk. We want to make sure also that when the client assesses the site for leaks, that they don't tug or twist the tubing of their site. They're at risk for protein loss. It can remove protein from the blood as well as excess fluids, waste, and electrolytes. So we need to increase dietary intake of protein and monitor their serum albumin levels. So we want to recommend a renal diet and increase the dietary protein for some of these patients. Now that's all going to be reflective on what we're seeing in their albumin. They could have hyperglycemia because of the hyperosmolarity of the dialysate, so glucose can be absorbed from the dialysate into the blood, and hyperlipidemia can also occur. So we're going to watch their serum glucose, and any insulin needs to be administered to maintain that glycemic control, and perhaps they need to go on some statins for their triglyceride control, their lipid therapy. We're going to teach the patients to watch their serum glucose and how to follow a diet and recommend a diet for them. Another complication, and the last one, is poor dialysate inflow or outflow, and perhaps the tubing becomes obstructed or twisted and causes a decrease in the flow. So what can we do about that? Well, we can rotate the catheter to facilitate inflow or outflow, reposition the client, like I said earlier, to help the fluid go in or out, careful milking of the tubing to break up the fibrin clot. And when I talk about milking, is to pull on it and try and break the clot up inside the tubing. We're going to check for any kinks or closed clamps if we're having trouble with the flow, and we're going to tell the client to avoid constipation by using stool softeners, because think if they're all constipated inside, they could be causing an obstruction too because they're filled up with stool. So we'll teach the patients how to check for kinks, how to milk the fibrin clot out if they need to, how to monitor the in and out flow, change positions, raise the dialysate bag if they need to improve flow, to prevent constipation, and to encourage them to use stool softeners if they are constipated.